our institute case. This is a private case, but she was not operated by me. She was operated somewhere else
Okay.
in another center. So I kept a record and sent to Majabin to make it in a
Okay.
format so that we can present in the meeting. And there was a little bit confusion in many of the neurologists, neurosurgeons, and oncologists. Okay, what is happening with this lady on the basis of the imaging?
Okay.
Okay.
Okay, sir. Perfect. So we have two amazing neuroradiologists with us. We will have their input. Okay, Dr. Mahjabin, can you please unmute yourself and start?
Assalamu alaikum.
Walaikum.
Good morning, everyone. So today we are going to discuss this patient. She is a 49-year-old female, known case of hypertension and depression, presented in OPD in August 2022 with complaint of numbness and weakness of left side of body since 2 months, fits and headache since 2 months. Past history was please move forward. This was the initial MRI in 2022, pre-operative, on which we can see that there is a well-defined lesion in the right parietal region, which is ISO to hypo on T1, hyper on T2, and hyper on FLAIR. It shows significant perilesional edema. On post-contrast images, we can see that there is vivid contrast enhancement with dural tail, suggestive of an extra-axial lesion, most likely a meningioma. She then underwent craniotomy and gross total resection in 2022. And she was fine and her progress was smooth post-operatively. She was discharged after a few days after surgery. This is the immediate post-op scan on which we can see that there is gross total dissection and the patient's recovery was also smooth post-operatively. Biopsy came out to be of anaplastic meningioma grade 3 with Chi index of 30 to 40%. She was then referred to an oncologist for further management of the case. Initially, she was advised for radiation therapy. She received 30 doses of conventional radiation therapy, which started from 3rd November up to 14 December. Meanwhile, she was on regular clinical and clinical follow-up by the primary surgeon as well. She's also on radiological follow-up. After that, again, we can see that this is the scan 20 days post-operative, on which we can see there is no residual. These are the post-contrast images.
I would like to have an opinion from Dr. Shumaila. Would you like to add something to the post?
Just a minute. I just want to open the images at my end as well because.
Oh, okay. We can ask, meanwhile you're doing that, we can ask Dr. Shayan if you want to add something to.
Yes, sure, please.
Thank you. Dr. Shayan.
Assalamu alaikum, everyone.
Assalamu alaikum.
So I think this is post cranioplasty, and we see that the flap is in place, and there is diffuse pachymeningeal enhancement beneath the flap, which appears slightly irregular as well on post-contrast images. And so most likely this represents post-operative changes.
Especially when it is 20 days post-op, right? So
yes,
typically we wait 6 weeks to say okay, post-op changes have gone down.
Yes, I agree. I agree because it's an early post-op. That's all.
ये कितने अरसे बाद हुआ था क्रेनियोप्लास्टी डॉक्टर महजबीन?
Sir, 1 week after the surgery. Radiation was started. She was operated on 31st August, and radiation was started in 3rd November.
The first surgery एक हफ्ते इंतजार करने की. Right. Yeah.
Dr. Atar, I already informed that This is not our case.
No, I understand. I just thought
Yeah.
कि maybe we have some information.
Okay.
कि उससे क्या ठीक चले आगे?
Okay, so these are the 5 months post-op scan. Again, we can see that there is no residue on T1 or T2 weighted images, even on post-contrast images. So next, please. Again, we can see on FLAIR images, there is just a subtle edema that's post-operative. Otherwise, there are no post-operative changes. Neither on contrast images. This is 5 months post-op. Then
Slide, there's slight enhancement on contrast, all right? पीछे जाइए. Under that, in the
flap.
meninges, right?
Yes, beneath the flap.
जी.
Yes.
But that again, you know.
Reactive, yes.
Yeah. ठीक, आगे चलिए.
Then 10 months post-op scan, we can see there's again subtle the hyperintense changes in the T2 images, and on post-contrast images again. Next, these are the FLAIR images, subtle edematous changes.
इनकी
FLAIR.
radiation कहाँ हुई थी इनकी?
I guess कराची में हुई थी, नहीं सर, sorry, निमरा में हुई थी.
निमरा में. ठीक, आगे चलिए. And right.
Again, on post-contrast images, we can
जी.
see no significant changes. This is 1 year post-op. On T1, there is nothing significant, but on FLAIR images, we can see that there are hyperintense changes on FLAIR as well as T2. And on post-contrast images, what is significant is a lesion. So please next, is a lesion deep-seated, the region of the corpus callosum more on the right side, which is showing ring enhancement, and it is having diffuse borders.
Radiation के
primary
अब ये तस्वीर radiation कितने अरसे के बाद की है?
Radiation, so ये है 1 year post-operative. That
Right,
is, the radiation was started 2 months post-operative.
So
August,
ये radiation
September.
खत्म होने के 8 महीने के बाद की लगभग, right?
Yes, sir.
जी, अच्छा ठीक, आगे चलिए.
अच्छा, डॉक्टर शायान, आपका क्या ख्याल है इस इमेज के उस?
As we see that there's a lot of periventricular hyperintensity on both the T2 and FLAIR, and now we see some enhancing lesion which is involving the corpus callosum. It may be within the radiation field. We don't know exactly what was the radiation field. So the first thought will be that of a radiation necrosis. Rather than a primary tumor, but we need to just follow this lesion.
डॉक्टर शुमाइल,
डॉक्टर शुमाइल, इसका हम परफ्यूजन स्कैन नहीं कर ले, MRI?
इसका परफ्यूजन स्कैन बिल्कुल कर
Yes.
सकते हैं. इसमें एक्चुअली इनिशियली जब बिल्कुल एक प्राइमरी लीजन से हमने स्टार्ट किया था, तो उसमें वेसोजेनिक एडिमा जो था दैट वाज ओनली इन राइट सेरेब्रल हेमिस्फीयर, क्योंकि वो एटिपिकल मेनिंजियोमा था, और दूसरा सेरेब्रल हेमिस्फीयर जो था देयर वाज नो एडिमा इन दैट. So when we started looking at the post-operative and post-radiotherapy scan, we could appreciate that the edema was started in the radiation field in the contralateral hemisphere as well. So the changes are gradually increasing in every passing scan, and that goes more obviously in favor of radiation necrosis. There is extensive vasogenic edema. जो इससे पिछले स्कैन आपने दिखाए थे जिसमें लीजन अपीयर नहीं हुआ था, उसमें भी दूसरे हेमिस्फेयर में भी एडिमा आना शुरू हो गया था पेरीवेंट्रिकुलर रीजन में. So this is yes going in favor of radiation necrosis. और इसमें बस वही है, ज़ाहिर है 3-4 जो डिफरेंट चीज़ें, we can take help from perfusion, we can take help from PET, or somebody can go and get a biopsy. These are the 3 or 4 different routes we can use depending on the availability of different imaging modalities which you have in the center.
I think we should go for perfusion MRI, and अगर उसमें भी फिर कोई डिसीजन ना हो पाए तो फिर बापसी शुड बी द ओनली थिंग, बट चांसेस ऑफ रेडिएशन नेक्रोसिस भी है बिकॉज शी रिसीव 30 फ्रैक्शन विच मोस्ट प्रोबेबली शी बिकॉज इट वाज एनाप्लास्टिक, सो उन्होंने 60 ग्रेड दिया होगा, जिसमें हमारे पास भी इस तरह केसेस आते हैं। व्हेन वी डू परफ्यूजन स्कैन तो उसमें वो ज्यादातर केसेस में रेडिएशन नेक्रोसिस आ जाता है।
एंड कंट्रोल्ड फील्ड नहीं होगा शायद, है ना? आई मीन क्योंकि इट लुक्स लाइक के इट वाज गिवन टू अ मच लार्जर फील्ड।
आई थिंक सो, आई
वो
थिंक
अगर
सो।
देख ले कोई कि वो फील्ड कंट्रोल था कि नहीं था, वाज दैट लाइक 1
हाँ,
सेंटीमीटर?
ये इस केस में अगर वो इनके पास वो सिमुलेशन की फिल्म पोर्टल्स होते ना, तो इट वुड
जी
हैव
जी
मेड मच मोर क्लियर कि कितने एरिया को रेडिएट किया गया है, एंड इफ इट इज कमिंग इन द रेडिएशन फील्ड
जी
तो
जी
मोस्ट प्रोबेबली इट इज।
इसमें
आई
आगे
एग्री।
और भी तो इमेजेस हैं जिसमें सर्जिकल बेड में भी कुछ आ रहा है, मेरा ख्याल है अभी शेयर करेंगी।
आगे चले। हाँ
So there's another area in the surgical bed where there was only thickening and pachymeningeal enhancement. So we can see another nodular area with peripheral enhancement.
जी। उसमें कोलिन
एक्चुअली
पीक आ रहा है? कोलिन पीक नहीं आ रहा है क्या, है ना?
देखिए बहुत नॉइजी सा स्पेक्ट्रम है,
जी
शिमिंग वगैरह प्रॉपर नहीं है, बट ऑल आई कैन अप्रिशिएट इज दैट देयर इज अ लिपिड लेक्टेड डबलेट, सारी इन्वर्जन हुई हुई है, सारे उसकी
जी
जो
बिल्कुल
स्पेक्ट्रम है उसकी।
बिल्कुल।
सो बट लिपिड लेक्टेड डबलेट एक नजर आ रहा है विच इज गोइंग इन फेवर ऑफ नेक्रोसिस, बट ये नेक्रोसिस तो बहुत नॉन स्पेसिफिक सी बात है, क्योंकि ये आपको ट्यूमर नेक्रोसिस में भी मिल सकता है, इन्फेक्टिव नेक्रोसिस में भी मिल सकता है। सो आई वुड स्टिक विद द बेसलाइन इमेजेस इंस्टेड ऑफ फोकसिंग more on the spectroscopy images and the
राइट।
history and the follow-up serial imaging, all that goes together.
or at least this is consistent with our assessment so far that this is radiation necrosis,
Yes,
right? It's
yes,
not inconsistent with that, जी।
yes.
Can I ask one question?
जी डॉक्टर यास।
We included this case just because the many radiologists say that this is a GBM. So there are definitely two lesions on the one image, and they show there's the one is the recurrence of the tumor and other is the GBM. So I was not in favor that this can be a GBM. So then we investigate, though she was operated and irradiated somewhere else, but then they came to me in my private clinic and they were investigated, and I was not in favor that this is another tumor like the GBM. So I contacted to a radiologist in Hyderabad, and he's denied that this is a GBM. And one question to Dr. Shumaila, that how can we exclude, is this the tumor necrosis or a glial tumor? And second thing is that what are the tools in radiology which we should take or write to the imaging person so that we can exclude the tumor from the necrosis?
देखिए रेडियोलॉजी जो है ना, इट इज जस्ट अ पार्ट ऑफ दैट जिक्सा पजल थ्रू विच वी आर ट्राइंग टू सॉल्व अ पेशेंट्स प्रॉब्लम। अगर हिस्ट्री और प्रॉपर इमेजिंग, सीरियल इमेजिंग रेडियोलॉजिस्ट को ना मिले तो देयर कैन बी अ वैरायटी ऑफ ओपिनियंस, एंड व्हेन आई एम फॉलोइंग अ केस फ्रॉम स्टार्ट टिल एंड। मैं आपको एक छोटी सी एग्जांपल देती हूँ कि अभी पिछले दिनों मेरे पास एक एटॉमिक एनर्जी से पेशेंट का स्कैन आया जिसके ब्रेन स्टेम में एक लीजन था जो कि 15 दिन में डबल से भी ज्यादा साइज में हो गया था, and it was reported at 3 different places, and there was a question between demyelination and glioma, and बहुत अच्छे अच्छे रेडियोलॉजिस्ट ने उसको बहुत डिफरेंट तरह रिपोर्ट किया था। व्हेन आई प्रोब्ड इन द हिस्ट्री, देयर वाज अ हिस्ट्री ऑफ सीए थायराइड which was operated 1 year back, और पेशेंट अफगानी था, लैंग्वेज बैरियर से कम्युनिकेट नहीं हुआ, basically that was metastasis. Then I discussed with those radiologists because I knew them, and they also agreed with my opinion, but at the time of reporting they did not have history. So हिस्ट्री के बगैर तो हम रेडियोलॉजिस्ट चल ही नहीं सकते हैं। अगर मेरे पास हिस्ट्री है कि एक जगह पे सर्जरी हुई, रेडिएशन फील्ड इसका ये था और अब ये चीज़ अपीयर हो रही है, तो मेरे पास इमेजिंग के जो टूल्स एक्स्ट्रा हेल्प कर रहे हैं वो तो कर ही रहे हैं, बट मेन चीज़ है कि आई हैव द फुल क्लिनिकल पिक्चर, क्योंकि उसके बगैर मैं भी नहीं चल सकती, कोई रेडियोलॉजिस्ट नहीं चल सकता। नेक्स्ट कम्स द डिफरेंस बिटवीन रेडिएशन नेक्रोसिस एंड ग्लायोब्लास्टोमा ऑन द बेसिस ऑफ एमआर, जैसे आप कह रहे हैं। तो एमआर में पहली बात ये कि दिस इज द रेडिएशन पोर्टल, दोनों तरफ पेरीलीजनल एडीमा बहुत ज्यादा है। जो मिडलाइन लीजन्स होती हैं क्रॉसिंग द कॉर्पस कैलोजम, उसमें ज़ाहिर है हमारे पास 3-4 डिफरेंशियल्स हैं, जिसमें ग्लायोब्लास्टोमा नंबर 1 पे आता है, और हम जो है वो 50 ईयर्स से ऊपर उसको सबसे पहले कंसिडर करते हैं. But now I have a history that there is there was a meningioma which was operated, and this is radiation field. There is significant perilesional edema, and then over serial imaging there is appearance of similar area in the surgical bed. So is particular case mein I will consider radiation necrosis. Otherwise, I will definitely keep GBM as the topmost differential, because primary brain lesions, solitary primary midline crossing brain lesions में सबसे पहले हमें GBM ही सोचना चाहिए. If there had been not that much necrosis, I would have considered lymphoma as well. अगर solid enhancement होती, अगर बहुत rapidly progressive कोई चीज़ होती, तो मैं TB और ये चीज़ें भी सोचती अगर थोड़ा सा जो है वो enhancement pattern different, ज़्यादा bunch of ring enhancing lesions होता. So on the basis of only imaging, if I don't have a history, तो मैं GBM को पहले रखती. लेकिन मुझे यहाँ पोस्ट सर्जिकल चेंजेस नज़र आ रही हैं. जब पोस्ट सर्जिकल चेंजेस नज़र आ रही हैं, बेशक मेरे पास पुराने इमेजेस ना भी हों, तो मैं ज़रूर कंसिडर करूँगी कि ये पेशेंट की पुरानी हिस्ट्री क्या थी, इसमें क्या ऑपरेट हुआ है. बाकी ऑन द बेसिस ऑफ दिस यू कांट टेल. हाँ, स्पेक्ट्रो एट टाइम्स हेल्प. आपको कोलिन के पीक्स बहुत अच्छे मिल जाते हैं, जो कि प्राइमरी नियोप्लास्टिक लीजन की फेवर में जा रहे होते हैं. But I will again insist that it is just a mixture of things which lead to a radiological conclusion as well.
Okay,
I would,
thank you.
like
Thank you,
Dr.
Dr.
Shayan to
Shamala.
add to this.
Yes. Ji.
I just want to add, I agree with whatever Dr. Shumala has said, but just to add to it, a very important tool is the diffusion weighted imaging, which we should look at every scan. Since we know that this is a radiation field and we are considering radiation necrosis, so I would like to look at the diffusion weighted imaging as well. So it might give some clue if there are areas of restriction, then that will favor tumor rather than radiation necrosis. And again, if still I have a query, I will go for a perfusion scan just to exclude radiation necrosis.
मेरे ख्याल में perfusion तो डॉक्टर मजहर कह ही रहे हैं. We should just go ahead with that, with perfusion anyway, right? And that
Yes,
will
agreed.
give us
Because we
more.
have multifocal lesions,
yeah,
and at least we should exclude tumor.
Right. और उसके
और
बाद जो
डॉक्टर-
है, अगर वो नहीं उसमें भी अगर जवाब नहीं आता है, तब फिर as I think Dr. Riaz and Dr. Mazhar both are saying one can go for biopsy. अगर वो बढ़ता ही जा रहा है, अगर, है ना?
And serial imaging also, sir. I think that's what.
हाँ, वो serial imaging करते जाएंगे, बढ़ता जा रहा है अगर, तो फिर then otherwise
Dr. Azhar, if it is a radiation necrosis in a healthy patient is healthy and she has only the left-sided weakness, she is ambulatory. So what would be, as a neurosurgeon, we can think about to solve the problem of the patient? Is it possible that we continue the steroids for a long period of time, or we can have a other solution to cope with?
So yeah, I mean, once radiation necrosis starts to set in, it becomes very difficult task. So a combination of steroids and combination of antiplatelet agents, Avastin, and all those things can start to work. Anti-VEGF will should work very well on this one. Yes, thank you, Adnan. So yeah, those are the things. Really. I mean, and it's not so easy to control, but it has its own time frame. वो आस्ते आस्ते फिर subside कर जाता है.
Dr. Adnan, would you like to add some? Sorry, Ji, Dr. Riaz.
So if it is not increasing in size, so we think that we are in a favor of the radiation necrosis. But if
so size to increase किया है अभी, और हो सकता है और increase करे. So radiation necrosis का size increase करता है. The time frames are different. Sometimes it can go on increasing for a few months. Sometimes they can go on increasing for a whole year. So it really tests your patience.
Okay.
Dr. Adnan कुछ कह रहे थे शायद.
Dr. Adnan ji, कुछ कहना चाहते हैं, sir.
No, I just agree with the discussion. Right now, we really don't know whether this is necrosis or whether this is tumor. And I guess I agree with serial imaging follow-up and get a perfusion scan. And in cases where it is documented to be radiation necrosis and patient is getting symptomatic, there is data to give anti-VEGF, which is Avastin, and that sometimes help. But then again, we need to know, because what will come next? What if he continues to progress on Avastin and we don't know whether this is tumor or radiation necrosis? Then we cannot just go on chemotherapy. So in cases where we have clear diagnosis, that's where we as oncologists are clear what my next plan will be.
So basically what you're saying is that we चल रही स्टेरॉइड्स एंटी VEGF भी शुरू कर देते
नहीं,
हैं
अगर आप करेंगे
और
ना तो
Avastin-
फिर वो दोनों में हेल्प करेगी, फिर आप नहीं बता पाएंगे
और 3 महीने बाद
हम्म।
अगर को लगता है कि नहीं फर्क पड़ रहा है, बढ़ते ही जा रहा है, तो फिर देन बायोप्सी एमआर स्पेक्ट्रोस्कोपी अभी करा लें
That's
और
right.
3 महीने बाद with 3 months of Avastin and all that increase in size, then we just do a biopsy. Does
If
that
you
make
can even do it 2
Riaz?
months, if
अच्छा,
it is high grade, you
yeah.
don't have to wait for 3 months, right?
Dr. Riaz, Dr. Mazhar, does that make sense? Dr. Mazhar,
Definitely, if we are in a confusional state, then we have to keep this patient and follow up for repeated MRI, so that if some imaging shows that there's an increase in the problem or size, then we can think of the tumor.
हाँ, that's right. लेकिन अभी तो हम कर रहे हैं ना perfusion scan.
But is it possible? I'm towards Dr. Athar. You have a very huge experience of the in oncology. That is it possible that within a year of operating a meningioma after the radiation, the patient developed the
but it's a very rare entity, and the radiation was not controlled, so there is always a possibility that it is radiation-induced glioma, which has been written in literature as well. So वो ध्यान में रखना पड़ेगा. अब उसका time frame जो है typically was many years, close to a decade बन जाता था for after radiation getting into. So this is too early, as you're saying, कि उसके फौरन बाद हो गया. So that's why all of us, including Dr. Shamala and Dr. Shayan, are thinking of radiation necrosis as the first option.
okay.
Dr. Mazhar, anything else you would like to
नहीं,
add?
I think I agree कि secondary tumor radiation से इतना जल्दी 1 साल के अंदर नहीं होता, and it's more the chances of necrosis rather than another tumor. So I agree. We should get a perfusion MRI and then from there follow it up again कि आप उसमें क्या report आती है. And then अगर उसमें भी confusion है और वो clear नहीं है, then biopsy is the only answer.
वो उसमें एक ट्रायल देना चाह रहे हैं डॉक्टर नाज जब्बार, उसका भी Avastin का भी.
Okay, Avastin का.
नहीं,
Right.
not now. After, we have diagnosis, then only.
Diagnosis, exactly. That's
Yeah.
what I was saying.
So after biopsy.
हाँ, exactly.
Yes.
क्योंकि
अभी
ऐसे तो आप
नहीं.
Avastin नहीं sign कर सकते ना.
Okay, let me reiterate what I said. I was saying कि हमें Avastin का role तब होता है when we have a definitive diagnosis, because अगर वो उस पे भी progress करता है तो we know कि whether this was radiation necrosis or this was tumor. अगर हम अभी बगैर diagnosis कर देंगे तो Avastin can help in both cases and we will not be able to differentiate. So that's why the initial plan of doing a perfusion scan now, MR spec now, follow it up in 2 months. If it still grows, do a biopsy and then treat accordingly.
That makes better sense, right? So MR perfusion scan, follow up in 2 months time, growth continues, then biopsy, and then based on histopathology, whatever we decide.